Our first-line medication is a neonatal form of methadone. It's much more longer acting, so it gives us a much more steady blood level. And because it is long half-life, as we wean it down, the blood levels come down fairly slowly. We feel pretty good about it. We've done a couple of drug trials, medication trials, looking at phenobarb and morphine as other alternatives, and we feel pretty comfortable that methadone right now is our strongest treatment option. We've looked at a variation in which babies need to be treated, variation in response to treatment, and the things we feel make a difference. Number one is what medication the baby was exposed to in utero. So the baby who's exposed to methadone will be a little bit more likely to be treated than the baby exposed to Subutex, versus the baby exposed to a chronic pain medication is less likely to have any withdrawal. We also then have looked at breastfeeding. So the mom who is breastfeeding, the baby is less likely to be treated. And if the baby is treated, the length of stay is shorter, and that holds up for methadone, Subutex, and prescribed opiates. We've also looked at the genetics of opiate metabolism, and have found that that is a major contributor to whether the baby needs to be treated or not, and then also the response to treatment. It seems counterintuitive that you would expect that the higher mom's medication dose, the more likely it is that the baby would need to be treated. And I'm sorry to say it doesn't hold up, that the mom's dose has no effect on whether or not the baby needs to be treated.